amazing life, of her own. And so our goal today is to explore hyperbaric oxygen. Fortunately, I've been blessed with the opportunity for the last 2 days to interview Dr. Harch and develop some of the HBOT News Network's conversation series. And we covered much of his book. And so one thing that I would recommend here is the Oxygen Revolution. It's an essential guide to understanding hyperbaric oxygen and how it might benefit you or your family or someone that you care about for many of the ills that society faces. And so without further ado, welcome, Dr. Harch, Juliet.
Thank you.
Thank you. Great to be here.
Thank you. And in our many sessions, I think maybe we'll come out with 8 conversations covering many topics. We touched on some that we decided that we would highlight today.
Okay.
And of course they go in much greater detail in the conversations that we've had. But one of the areas of focus that I think we're compelled to talk about is some of the things that afflict us right at the very beginning of life.
Yes.
And so one of the ones that I think most people are familiar with is cerebral palsy. And so if you could share with us your experience with that and some of what you've learned are the causes of it, and what hyperbaric oxygen represents to that community that deals with that, would be wonderful.
Sure. Be a pleasure. And before we do that, I just want to elaborate on one thing that you said, about every good man and a woman behind them. What I'm doing and where we are today, all of this would not have happened without Juliet. The title of that book, The Oxygen Revolution, was from her. That was her title. But really everything that has come about and I've been able to do is a result of, she's a nurse also. The whole COVID announcement about hyperbaric oxygen came about because of her. So yes, it's not, behind every good man is a good woman. I mean, alongside every good man, we're a pair, and what we're doing here and what has happened, it could not have happened without her. So I just wanted to get that out of the way and up front. But, so CP, yes. So CP, it is a fixed motor deficit neurological condition in children that consists of injury to the motor tracts in the brain. And there are kind of 2 groups of causes, if you will. Premature babies who are born, and the immature part of the brain, the central part, it's the last place the blood vessels develop, and they are prone, when you're born prematurely, to spontaneously rupture and bleed. And that causes destruction of that white matter and is responsible for, I don't know, as much as 2/3 of the CP cases. The others are usually the result of something that went wrong at birth. Either the mother had a problem, the placenta got separated, the umbilical cord ruptures, the child is born through their own placenta and there's extreme bleeding, or some other problem that happens, or in the neonatal or period afterwards that injures the brain. But both of them, regardless of the nature of preemie or birth-related, etc., they are wounds to the brain that primarily injure the motor tracts. However, if it's one, let's say the birth injury, where the mother's blood pressure dropped precipitously and the whole child is exposed to a low blood flow, low oxygen insult, the whole brain can be injured. So if you look at CP, many of these children have cognitive deficits and problems with behavior, emotional dysregulation, and about a quarter of them have seizures. So these are wounds of the brain. And as we discussed at the very outset of this program, after I made this discovery in our divers with brain decompression sickness, using a different approach and dose of hyperbaric therapy than what the Navy had taught us and what was the established dogma on how you treat, and found that we could treat long after the Navy said you could get any neurological recovery. And we were treating boxers as well. our director of research went to a cerebral palsy support group meeting in Mobile, Alabama, and stood up and said, "We can treat cerebral palsy." And he called me up the next day and said, "You're going to be hearing from some others with cerebral palsy children." And I almost had a fit. I mean, we were looking at boxers and divers and people with stroke, chronic injury. And now here are going to be referred these children with CP. And I had to stop myself and say, wait a minute, how did this all happen? It was by opening my mind and trying to remove the restrictions and the confines of what I had been taught to maybe think a little bit differently and be more expansive. And it should be no different with these children and CP. So the first one got referred, a little 4-year-old boy with a precipitous birth injury, had a bleed in the brain, and now at 4 years of age was just a floppy little kid. Couldn't stand, uncoordinated, no speech, drooling, peg tube for feeding. It just, and we imaged him, the brain blood flow imaging. Next day put him in the chamber, repeated it, and the imaging looked better. And I was like, oh my God. It's the same pattern we saw with the divers, the boxers, the stroke patients. Maybe we can do something. We treated this child, and by 80 hyperbaric treatments, this little boy was walking with just fingertip support for balance. And it was, it was just another one of these amazing experiences that made me realize we had a treatment for brain injury.
And since then, you've treated many.
A couple hundred with that diagnosis.
And seen similar results.
Yes, a range of it. And as we talked about, I tell parents when they ask about it that I can give them a probability of 80 to 85% that their child will see improvement with this therapy. And the other 15%, well, they just don't respond, or maybe I couldn't quite get the dose right. But, I just tell them it's not perfect, but there's a very good chance. This is a wound in the brain. This is a treatment in a broad-based way for many, many, many different types of wounds. And that regardless of how old that child is, even into adulthood, they can still benefit from this therapy, have a good chance of it.
And as I recall, even into their 20s.
Yes.
So it's not...
I treated one 33-year-old man.
Yeah, so improvement. Amazing.
A little bit with him, but he had a very curious one. He had an intrauterine stroke. So by then it was a 33-year-old stroke. And when we imaged him, it was very, very well described. So we didn't see that gradient of idling neurons. And I told him, I said, we might not see much change with you. And so with him it was a little more subtle. He was a little more energetic, a little sharper cognitively, but some of the other things didn't really show much change.
So in our conversation, we talked a lot about some international work and some other places, I think like Brazil, places like that. And I proposed this I want to say theory, idea, that when you look at an athlete and you see him on the playing field in, let's say, high school or younger, some are just natural athletes and some are probably shouldn't be playing the sport. And then there was me playing soccer in between. In 6 years, I was still getting plenty of splinters on the bench. And so with birth being such a difficult process to go through, very stressful on the head, of course the largest part of your body at that point, that is it possible that all of us are afflicted, even a small degree, that it's doing something. And
potentially.
So, well, I noticed with 40 hyperbaric treatments that I did that my coordination got better. And so I'm just saying that maybe we all should do some just to try it and see it's helping us in some way.
There should be a hyperbaric chamber in every delivery room.
CP would be...
This was what our goal was. Yeah.
85% of CP might have been eradicated. And so then
maybe someday.
Maybe, yeah. So then we moved on, we talked about autism. And I know that when you talk to the autistic societies and individuals that have dedicated themselves to raising the money to help families that are out of resources, it's very difficult for the family. That they don't really want to hear much about it, And it was interesting to learn that what you've learned is that often, similar like cerebral palsy, it can be a brain injury at birth and not so focused on the vaccines, although that could be a factor, of course. And so maybe you could share some of your experience with that.
Yes. Well, it goes to the simple question, what is autism? What is the cause of autism? It was originally defined as a psychiatric disorder of childhood. Now, what psychiatric condition does a 2-year-old child have? Okay, I mean, you can abuse them and do other things to them, and they are withdrawn and can have, behavioral abnormalities, but this lack of speech, this lack of social engagement, repetitive behaviors, all of these things, a psychiatric condition, I mean, it's almost a joke. And yet the information is out there, voluminous information, that there are physical and anatomic abnormalities in these children's brains where they very likely have been injured by some process. And so it then falls into that category of what is treatable with hyperbaric oxygen. In a very broad way, this is a treatment for wounding conditions in the human body. Well, in animals too, but wounding conditions. And that actually covers a very wide range and things that we don't think of as wounds. A stroke, internal wounds. They are no different than a lack of blood supply to, let's say, an artery in the leg that causes an ulcer on the leg. But they're internal, and we haven't thought of them as wounds, but it is a wound. And there's just all sorts of information about abnormalities in these children's brain with autism. And what it appears is that it largely is an inflammatory process, very likely started by different environmental insults. So I think I mentioned to you in 2001 when Representative Dan Burton of Indiana, U.S. House of Representatives, had his oversight hearings on autism based on his grandson who had autism. The 5th year of it, he finally said, look, we need to talk about treatment here because we're not getting anywhere with causation. And so I got invited, and what I went and showed them was, this is not a psychiatric one. The first 5 cases that I treated of autism all had birth injuries of some type that these children from the earliest, almost coming home, were abnormal. And eventually the expression of it was the behavioral, social, and repetitive behavior, the things that made them fit in the classification of autism. And here they were, the brain imaging was abnormal, and we treated them, they were improved. So physical injury to the brain, and our figure, and one of the most prominent people who has done this and published his experience on it, Dr. Dan Rosnell, we have an identical response rate. It's about 80% of these children respond to this therapy, hyperbaric oxygen.
So one of the 2 common components here that you mentioned for cerebral palsy and autism we talked about extensively was inflammatory response. And,
yes.
And sort of the subtitle in your book is about gene therapy and the importance of hyperbaric oxygen as an anti-inflammatory and the gene therapy and the number of genes it impacts. And so not surprising, right, that this powerful anti-inflammatory is going to help something that's inflammatory in nature.
Exactly, which is why it helps in COVID, why it helps in so many different diseases. So hyperbaric oxygen has been so misunderstood for 360 years. And essentially what it is a manipulation of all of our sensitivity to changes in environmental pressure and oxygen levels. And that's what we're doing. We're putting a patient in an environment where we are exposing them to changes in oxygen and pressure. And the effect, the dominant effect, is on our DNA. So cells in areas of wounding are very sensitive to this, and it's now been shown, finally. Beginning in '94, the concept was put out. What are we doing? We're healing wounds. Well, to heal wounds, you've got to grow new tissue. To grow new tissue, you have to stimulate cells to multiply and divide. To multiply and divide, you have to stimulate the nucleus, where the nucleus begins cell division. Well, it kind of begs the question, what are you doing? Somehow we're impacting the DNA, something in the nucleus to begin that division process. And so the concept didn't really take hold until doctors started individually picking off gene products, like a protein or an enzyme made by a particular gene, did hyperbaric oxygen in a situation where there was a problem with it, and measured an increase in that gene product. And so the idea was, wait a minute, we're signaling this. But then in 2008, they took human endothelial cells, the most reactive cells in our body, but they lined every tiny blood vessel in our body, every organ, put them in a petri dish, and gave them a single hyperbaric treatment, and measured, now with the technology that was available, gene output for the next 24 hours. At the end of 24 hours, over 40%, 8,101 of our 19,000 protein coding genes that control all the functions in our body were either turned on or turned off. Largest clustered turned on were the anti-inflammatory genes and the growth and repair hormone genes. And the largest clusters turned off were the pro-inflammatory genes and the ones that coded cell death. So every treatment, we are stimulating growth and repair and inhibiting inflammation and turning off programmed cell death.
Well, and after reading, that portion of your book where you talked about the 8,101 genes that
Yes.
were regulated, I went and I looked up the study and was able to download the list of the genes, and so put it in a spreadsheet. And I was reading this book.
Engineer.
Well, I was reading this book, Lifespan, by I think David Sinclair, Dr.
Yes.
David Sinclair.
Right.
And he was very focused on the sirtuin genes, and I was at that point really interested, like, are there sirtuin genes in this list? Because they're working, I think it's the Harvard Longevity Institute, I think is the name.
Yes.
They're working to, biohack the genome and come up with some approach to stimulating, and so of course I found them. And so I'm sure you're aware of that.
Yeah, it's like the Wizard of Oz, what's the moral of the story there? You're gonna look all over for the answers, what you are, but the answer's right there at home. It's right in our genes, and hyperbaric oxygen therapy for it. And we came on this from the treatment of our first demented patient in 1989. It was a demented diver. And this improved him, and it's like, wait a minute, dementia, this is an end-of-life phenomenon, a senescence, the nervous system dialing down or decaying down. And here we are reversing that. And then by 95, I treated a genetic premature aging syndrome, ceroid lipofuscinosis of the brain. It is an abnormality of a certain fatty acid in the membranes of our cells, primarily in the brain. And they all die by 25 years of age. And we treated this young woman at 19, and we were able to document neurological improvement and improvement on SPECT brain imaging. And over the years, it became so obvious, well, wait a minute, we're acting at the DNA. Where is aging? It is a DNA phenomenon, senescence. The cells stop dividing, the telomeres get short, etc. And so what ended up happening is, in 2004, I was invited to give a lecture at an anti-aging conference. And I had proposed that this may be the fountain of youth at last, that we have a mechanism of delaying aging and actually rejuvenating to some degree. So, like my wife, she's 130 years old. You never know that, right? But,
Well, she did share with you that she's 600 and something treatments in.
Over
Yeah.
600 treatments.
And you have, I think, a personal story.
Yeah.
Would you like to share that?
Yeah, I went to Tony Robbins and Dr. Harari's AI place. They do a head-to-toe evaluation. Just to sum it up, I am negatively aging 16% per year, which means I'm getting younger 16% per year.
Mrs. Benjamin Button.
So my chronological age is 67. My internal age is 47.
But why?
Well-
Tell them the punchline. You have chronic progressive multiple sclerosis. You've had it for 22 years that we know of.
Right.
So, 22 years into chronic progressive MS, you should be
Dead.
wheelchair or bedbound or dead.
Yeah. Or
And
or
yet-
bed bound with a feeding tube and drooling,
And on MRI, your MRI has not changed in 15 years.
right?
And neurologically, you
I dance,
couldn't
I
guess
run,
that you've
I
got
work
a
more than
chronic
full-time.
progressive degenerative disorder.
How often do you do hyperbaric treatments now?
Well, Dr. Harch would like me to do one a week. Sometimes I'm too busy, living life and working, so I don't. But to keep me at clinical plateau, my maintenance dose is one a week.
But
You've done some 600.
she goes in the chamber.
Yeah, but I started getting hyperbarics in 2000.
Oh, so you've done 600 something treatments.
Yeah,
Is that-
but-
You track that. Yeah.
Yeah, but we also have a patient
Yeah.
that we treat in a multi-place
Right.
chamber that she goes in with that patient frequently.
She's getting the pressure.
Yeah,
Yeah.
she's getting pressure and some
And
embedded
sometimes I
oxygen.
put the oxygen.
Yeah.
So I've gotten some blocks of, not exactly 40, because there are other nurses that go in with her, but I've gotten a lot more treatment over the last 3 years that I've been taking care of this elderly stroke patient inside a really big multi-place chamber, like the chambers that you have. So,
Well,
with
so-
all of that
Beneficial
combined,
effect.
yeah,
Well, and MS, afflicts all ages,
yeah.
right? And so.
She's getting younger, I'm getting older. I'm gonna get cycled out pretty soon.
Never gets sick.
Okay, so let's circle back to the children.
Yes.
And one of the things that I think has struck me since we first met in Albuquerque in 2014, which I remember, I'm sure you don't remember me, because I was likely the only engineer in the room.
We do.
I think.
I remember
You
you.
stood out, you're note-taking.
And so one of the things that I learned was the 13 or 14 indications the FDA has cleared, and one of those was burns. And somebody inevitably at these conferences presents on burns, and so a friend of mine was heavily engaged with the Shriners, and the Shriners, I think perhaps the wealthiest nonprofit maybe in the world. I think they have 22 some odd children's hospitals where children are treated for free, as I understand it. Never taken advantage of that, but I believe that's the case. Well, he raised the question when we were talking about the FDA-approved indications, or cleared indications, I should say, that there were 3 burn hospitals for children. And so he thought, well, we need to talk to them and let's find out who's in charge. And he found out, because of involvement with the Shriners, who was in charge. And we ended up with this doctor down in Galveston who was overseeing the 3 hospitals. And we brought up Paul, what's his?
Cianci.
Cianci. He wrote up the whole study that got the approval, or
He did some of the studies,
yeah, so he.
but he has written a summary of the literature and the argument that hyperbaric oxygen should be used in burns.
So we sent that to this doctor in Galveston and set up a call, and I wanted him to be on the call with Cianci. And he would refuse to take my calls after that. Now, he's dealing with children with burns, and I'm thinking, if this is what I believe it is, reduce the scarring, the pain, eliminate skin grafting, all of this great stuff, he would be really interested. And then I dove into it a little deeper to find that he was a plastic surgeon and really understood the sort of the rice bowl concept. This was going to take rice out of his rice bowl, and as a result, he wasn't interested. And for me, that was very sad, because I can empathize with a child with burns, that without having those burns, just how devastating that might be in my life or their life, or some young kid. And so for me, this raises 2 issues that I'd like you to touch on. And one of them is the FDA clears these indications. There's 13 of them, but we don't see them widely used. That's the first part. And then the question is and really part of that is why we don't see it used, and why doctors are not educated. And as you had expressed in our conversation, getting your medical degree, did you get it at Johns Hopkins?
Yes.
Yeah, so at Johns Hopkins, they didn't teach you, if they taught you anything, it was snake oil. So if you could just touch on that, I think we all need to know why we don't know about it, why I didn't know about it, why most people don't know about it, and what we can do about that.
Well, the 13 indications were essentially recommended to the FDA by a group of hyperbaric doctors that the FDA saw counsel from. So hyperbarics came into the United States in about 1960, and by the late 70s, a lot of people were doing it. Insurance companies were getting billed Medicare, Medicaid, et cetera, and the FDA was getting around to having to clear for marketing the hyperbaric chamber manufacturers. And they went to hyperbaric physicians and said, well, what's this good for? And they gave them a list, I want to say it was 20-some diagnoses, and the FDA pared it down to the 13. But in 2001, when I went and met with the FDA to ask them, what kind of evidence do you need for new FDA-cleared indications? And they stated the evidence, and said, well, wait a minute. You don't have that level of evidence for 9 of those 13. And it's like they all tried to crawl under their desks and tables, and it was like, I said, well, where's the problem here? They said, well, we have to admit, we didn't really scrutinize the clinical data we were given back there in the 70s, and we just kind of approved these things. And so, that's what we're left with, and then reimbursement is based on that. But the bigger problem is my generation of doctors' understanding of this therapy. It has not been defined in a way that people can understand it in. 75% of American medical schools, according to a survey that one of my fellows did in 2014, teach nothing about this.
75% teach nothing about hyperbaric oxygen. I needed to repeat that. Go ahead.
And the other 25%, it's one lecture or part of a lecture on it. So there's very little exposure. And look what I was taught by my junior resident. The first rotation in the hospital there was internal medicine for me, basic clerkship. And I heard hyperbaric oxygen mentioned by some doctors in passing. And I asked my junior resident, who's your primary teacher, if you will, and of course there's faculty above and all of that, what this therapy was. And he told me, don't ever ask about it again. It's been thoroughly disproven, unscientific, charlatanism, snake oil sales, and fraud. That got tucked up in here, and that was gospel. I mean, I was at Johns Hopkins. And then 8 years later, I find myself in this diving medicine group, and I had the opportunity to learn about diving medicine and treat these divers along with the emergency medicine we were doing. And I had to go to these courses taught by the government. And here was all this science. And it's like, where is the disconnect here? And it has to do with the way this was defined, and then the way studies were done and misinterpreted. And as we talked about, to this day, it's still happening with the Department of Defense TBI studies, the studies on cerebral palsy, and not understanding that once you get in an enclosed space and you turn up the pressure and the oxygen level, your whole body, it is bioactive on. And so even small amounts, it's been shown in experiments that as much as less than a centimeter of water pressure is enough to induce bioactivity. And all living organisms are sensitive to changes in pressure and oxygen. So look at arthritic patients. They can tell you when a front rolls through, storm is coming, their joints sing, they're symptomatic. Similarly with high pressure systems, people generally feel better. But we're very sensitive to it, and that has not been acknowledged. And it's the root of this therapy. It was defined by those 13 diagnoses. So they made a definition that said, this is a treatment with 100% oxygen for certain recalcitrant, expensive, and otherwise hopeless medical conditions. Keyword certain. Who determines certain? I would argue every chronic medical condition we have is hopeless, otherwise, untreatable, etc., recalcitrant. We don't have treatment for chronic disease. But the certain is determined by that little group of doctors, and them putting it on a list that the insurance companies then recognize. And that's where the holdup is, part of it.
Well, one of the bigger battles being fought now with the FDA is brain injury. Of course,
Yes.
And a lot of what we've already just talked about is associated with the brain, the cerebral palsy, the autism, and all that. And even in the Research Triangle Park where we are here, I believe there's maybe 5,000, as many as 5,000 adolescent concussions, brain injuries a year. And so I have been with very senior psychiatrists to ask the question, if there's inflammation when you have a traumatic brain injury. And they're very reluctant to say yes. Now, so I know you're being kind to the medical profession, but to me, as an engineer and a non-medical professional, some of this is so obvious. You have the most powerful anti-inflammatory therapy available that we know about that was introduced to the world hundreds of years ago, and there's resistance to it. And so I just can't believe that they can't open their eyes and open up a simple document, understand the gene therapy part of it. So doctors need to grasp that and rethink what they were taught. I believe, I go back to the rice bowl theory, because that doctor had everything he needed to know. All he had to do was read this document. It was all organized and done for him, and didn't want to look any further.
But you got to explain the rice bowl. And what the study showed was it will reduce the number of plastic surgeries, debridements, and skin grafting procedures. And so it's a financial threat to him.
Yeah.
And this has been a lot of the problem with the application to neurological diagnoses and
And
the
to
hyperbaric medicine
And so
physicians.
MS, right?
To MS.
Can I just say something about MS?
Yes, of course.
So I have a neurologist, just so that I can get an MRI every year. So I go to him once a year, and when I'm in the waiting room, I look like a pharmaceutical rep compared to all the other people in the waiting room. They're in wheelchairs, they're drooling, they're stoned out, they've got canes, they're disheveled. And do you think that he would tell one other patient what I'm doing? No.
He knows
did not
me.
refer
He won't
one
acknowledge.
patient.
Won't acknowledge what we're doing, and he keeps saying, well, wow, we don't understand it. You're doing
really well.
You're doing great.
Whatever you're doing, keep doing it.
Whatever you're doing,
But
keep doing it.
He knows I'm doing hyperbaric.
You sure you don't want to try a
Harch.
drug? And she says, I'm getting 2 drugs. I'm getting pressure and oxygen. Well, whatever you're doing, okay.
Keep doing it.
How many years in a row, So,
15, now he
Yeah.
retired.
yeah.
Yeah. And my MRIs, like I have one big lesion on the top of my head that never changes. But I have the lesions from the year before are gone, and I'm developing new little lesions. So I'm always going to have primary progressive multiple sclerosis, but I'm not symptomatic. And the little lesions from the year before keep on healing. So it's just so amazing. I just wonder, why doesn't he tell anybody else? All these people are suffering and dying, and
There are published studies that are negative, meaning showing no effect. But the most rigorous study ever done was published in what is considered the most influential and highly respected medical journal in the world, the New England Journal of Medicine, in 1983 or 1985 by Dr. Boguslav Fischer. And it was supposed to be the definitive study funded by the MS Society to show that this didn't work, because Dr. Neubauer and others had been showing that MS patients were responding to hyperbaric therapy. A randomized, prospective, blinded trial, double-blinded, randomized, prospective, double-blinded blindedness, if you will, and it was positive. And Fisher ended up discredited. They took his chamber away. He ended up leaving NYU. But it is, to this date, the most rigorous study, and it's positive. And there are 70 centers in the United Kingdom operated by MS patients where they treat themselves under the direction of, used to be Dr. Philip James, who's now retired, but these are ongoing centers.
70 hyperbaric centers just for people with MS in the
Right.
UK, and it's not recognized in the United States.
Yeah, so
Or
there-
by the UK government, so, to be fair. Yeah.
So there you have it. And so here
Yeah.
we're talking about the brain. We have traumatic brain injury, we have
Right.
CP, we have MS, we have burns. If you look at the 13...
Wounds.
Yeah, they're all wounds, are they not, right? So you
Mhm.
look at the 13 indications cleared by the FDA, and it seems to me, from an engineering perspective, with basic biology and high school under my belt, that there's a connection and there's a lot of gaps. And so why, why is it that we have all these gaps and no one's looking at it? Well, then you look at the studies and they have been looked at. And my interpretation of it is everything goes right to the goal line, but nothing gets taken in. And so one of the things that I believe is that you can't patent oxygen. It's been around since the second day when the atmosphere and oxygen, showed up on the Earth. And
Oxygen is a God-given element,
yeah,
and it can't be patented.
can't be patented, or that patent ran out long ago, and the guy
Yeah.
who patented probably would never care about that.
Right.
And so that's the rice bowl theory, is that there's no money in it, so we need to have something that, we can have a higher margin. And so there's the business side of that.
Mhm.
And so it seems to me that inflammation, as has been brought up for the last 2 days quite a bit, is the driver with much of what we as humanity suffer from. So in the spirit of humanity, everyone needs to look at the opportunity of hyperbaric and see if it fits into their future. I know I'm preaching to the choir, but
Definitely,
Yeah,
yes.
Yeah,
Purpose the book was written.
yeah,
Go out and get this.
yeah. Look at the lives
It's a
of,
bypass of the medical profession is essentially what that book was. I couldn't believe when I found out how this worked and how it's a culture of medicine issue and the politics of medicine. Medicine is not science. It is not science. It is, a little bit of science and then practice habits and so on is driven by all sorts of other factors, financial, politics, egos, etc. And that's largely been the story of hyperbaric medicine. Misinformation, misunderstanding, badly done studies, misinterpretation of results, and then condemnation of it. And then after this gets going, and it's continually repeated, Juliet's perfect statement for this, condemnation before investigation, where a doctor will just in a knee-jerk fashion be asked about hyperbaric, oh, that doesn't work. Oh, that could kill you, makes people go blind. All these things come rolling out, and there's no factual basis for it. And the patients trusting their doctor and that he's the purveyor of knowledge and going to give you an unbiased opinion based on the scientific knowledge, they believe it. Well, he's the doctor, right? Well, no, he's grossly misinformed. He's expressing his opinion. And just like you go out and buy anything else, you need to call your doctor on it and say, well, what makes you say that? Or what evidence is there? And let them try to explain themselves. And why they would try to restrict you from getting this. Because really, I feel it's a criminal act. If you don't know something about something, if I'm a refrigerator salesman and somebody's asking me about a refrigerator and, some new development in a competitor, oh, that doesn't work, it's trash. Okay, well, what's the harm? I don't buy that refrigerator, I buy this one. But in the medical field, you disparage some therapy that has the potential to improve somebody. You've denied them that opportunity. And now, years later, what do you do about that? It's almost human nature. You can't, suppose you're proven wrong. Can you go back now and, oops, I'm sorry, geez, made a mistake.
Well, one of the
Right.
things I've noticed
There's
in the book,
liability associated with it.
one of the things in the book is you're a lot kinder to the medical profession. And
Well-
understanding of them, but I can imagine
Yes.
the frustration and the concern about the future and how it's been blocked.
Yeah.
And one of the things I learned was when I went to the doctor is ask them what they knew about it. And I recommend people that want to ask their doctor, because they trust their doctor, about hyperbaric oxygen, is just say, what do you know about it? Because I think the doctors in general, they're going to be honest. And they're going to tell you they don't know about it. But if you ask them if it's good for
It's a
you,
good doctor.
if you ask them if it's good for you, chances are they don't know about it, they weren't taught it, so it's probably not been proven.
And they fear endorsing something that you go do and you don't have a good outcome for. Then it's, you told me, you recommended this. And so they're very skittish about that. And the basis of it is they don't understand the therapy and what's going on.
Yeah, so
That's what we're trying to clear up here.
when you look at all these indications, and internationally, hyperbaric is used for I think it's well over 100, When you add them all the different countries and sort of the mix of what's being treated, that one thing they all have in common, of course, is the inflammatory condition.
So many of them, yes, and it's a treatment not for specific diseases, but the underlying disease processes. Those are basic, and they're common to many diseases. So when that hypercritical article was written in 1987, Hyperbaric Oxygen Therapy, a therapy in search of a disease, they cataloged, I gotta get the number right, it's either 132 or 139, 130 plus diagnoses that people had claimed hyperbaric oxygen was effective for us. Well, when I explained how this therapy works and that these are treatment of disease processes that are common to so many diseases, in the book I said, that may be a conservative number. It may be many more than 130 when we find out the dose, the right amount of pressure and the right amount of oxygen.
It's kind of like the theory food is medicine, right?
Yeah.
Eat the right food and you're going to be healthier.
Yes.
And,
Yes.
and so oxygen is the essential element of life. So if you introduce it, with pressure, so it gets into, and this is one of the areas we didn't discuss, is that your hemoglobin might be saturated. You might think you have oxygen. It's getting to all the vital organs. What does the pressure do to the oxygen that kicks off this gene therapy?
Well, there are two components there. We got to come back to one of them. But the higher you increase the pressure of oxygen, so right now we're all, I don't know what your altitude is here in
350
in Raleigh.
feet.
350 feet. All right, we're close to sea level. So our hemoglobin is roughly 98% saturated or so. If you just take a half a liter of oxygen by nasal cannula, we're going to be 100%, our hemoglobin is totally saturated with oxygen. And at that pressure, and room pressure, there's a certain amount of oxygen that's also dissolved in the liquid portion of the blood. All gases interfacing with a liquid are dissolved in it based on the pressure. And so when you go in a hyperbaric chamber, what we're doing, well, first of all, if you put more oxygen on, and eventually up to 100% pure oxygen, all that excess is being dissolved in the liquid portion. Well, the only limit to how much is the pressure we're at atmospherically. So go in a chamber now and we exceed atmospheric pressure, and you can go, really sky's the limit, although side effects are going to overtake you, and all of that gets dissolved in the liquid portion of the blood. And at 3 atmospheres blood, at 3 atmospheres of pressure, equivalent to 66 feet of seawater, if you were doing a scuba dive, we have enough oxygen in the liquid portion of our blood to where we don't need hemoglobin. And that was the kickoff article in 1960 of the Journal of Cardiovascular Research out of the Netherlands, where they took pigs, put them in a hyperbaric chamber, and as they pressurized them to 3 atmospheres on pure oxygen, withdrew all of their blood and replaced it with saline, salt water. So eventually their blood was faintly pink. And they were happy and alive as pigs in a hyperbaric chamber. And then they replaced their blood and brought them out, and they had a picture in the journal of the pig alive and well. And the point is that is the dissolved oxygen component, and that is what is freely available. So as you go in a chamber, that is what is freely available for signaling. But the other component is pressure itself. Barometric pressure is bioactive. It's like temperature. It's called a thermodynamic intensity parameter. And this has been the secret of hyperbaric medicine that nobody has appreciated, and why pressurized air has benefit. It is the barometric pressure itself that we are all sensitive to, as in weather fronts, etc. And so it is both the effect of pressure and the effect of that increased oxygen, and the different levels of them have been shown to activate different gene sets. So there's not only independent sets, there are overlapping ones, and there are interacting ones. So the pressure and the oxygen, and now throw in argon and other medical gases, and we've got this glorious therapy that is activating our genes, the net effect of which is due to the combination of these things.
Yeah, so that sort of raises the issue is that, and you've talked quite a bit about dosing.
Yes.
And the importance of dosing. And one of the things that I recognized going to the conferences is that was a lot of differing opinions about, what was the best dose, and dose being percentage of oxygen, primarily the pressure, and the different devices and the doctors that are using that. And then there's the home unit, people have the
Yes.
zip-up bag. And so what can you tell us, about your experience with dosing?
There are 4 components of dosing.
Well, yes, actually, there may even
4
be more,
components
but
of
yes.
dose.
Not just pressure and
The
oxygen.
dose, first of all, we got 2 drugs. We got oxygen, we got pressure. So it's how deep you go, how much oxygen is there, the level of pressure, how long you stay at that pressure. If you take air breaks in there where you drop the oxygen down, bring it back up, and then
How
when's
many-
your next treatment?
How many treatments you get, how long is your break? There are a lot of components.
Exactly. So there are a lot of things, and ultimately the dose is, you're trying to find out what works for you. We're all genetically different in this room. And now you, with your 39 years of life,
39 years ago.
Are the cumulative result of every insult that you've experienced. Some exposure to carbon monoxide, the foods that you've eaten, chemicals, pesticides, additives.
Soccer.
Soccer,
It's in the
heading, yes, trauma. All of these things chip away at the reserve capacity of your brain, just like lungs or any other organ in their reserve capacity. And so treating you, it's kind of folly to think that we're all gonna respond one size fits all. The only place that works is in the military. Soldier, what size? I'm a medium. Here's a large. You're a large soldier, right? Everybody gets the same size, but not, medicine. We're all different. And so it's trying to find out what works best for you.
And isn't that what the focus of the medical industry should be about?
Well,
Is taking
amen.
this God-given thing and just focus on how do we deliver it in the most effective way?
Exactly.
There's so much work to be done there.
Oh, yeah. We're finally getting there, though.
I heard a great slogan today, and it was from Jim Hooker, and regarding the veterans. Let's return them how we received them. Did I get it right, Jim?
That's close enough.
Let's return them how we got them, right?
That's it.
Yeah. So,
We're trying.
yeah.
And of course, the
Just-
PTSD was the eureka.
Yeah,
In there.
PTSD and brain injury, but it's very difficult to have a productive life with a brain injury. The veterans and the football players, we can just see what happens to them. You just can't have a family, a job, and, we owe it to our veterans to do everything we can for them. We have a treatment that will help them. We have a treatment that will put them back into a productive life. And we've just had so much resistance. When we were doing the veteran study, I was answering the phone, and it was the mothers and the wives that were calling. The veterans didn't call. They didn't call for several reasons. They didn't have the capacity to do their own research to see that there might have been something that could help them. And some of them lacked insight into, they didn't see that something was wrong with them, but their wives and their mothers knew. And it just takes a lot of work to get scheduled and all of that. They needed, those veterans were lucky to have a wife or a mother who cared. So we need to do something about that. And then, a lot of ex-NFL players are homeless on the streets. Like a lot of veterans are homeless on the street. Because you can't be productive with a brain injury. And sometimes you can't see the brain injury, especially with all the body armor that we have now in the service. They look okay.
Well, and
But-
then it gets misdiagnosed.
A lot of times it's misdiagnosed as psych.
And see, like autism, where is the chronic condition for mild traumatic brain injury classified? It's in the psychiatric manual.
Mhm.
Persistent post-concussion syndrome is considered a psychiatric disorder. So a physical injury to the brain damages primarily the white matter, and yes, if it's not bad enough, symptomatically people can recover. Such that from simple concussion, within generally 10 days, 90% of people, 85% are not symptomatic. And what's happened is the 10% with those mild concussions who had persistent symptoms, it's deemed a psychiatric problem. There's something wrong with you. Everybody else gets better. What's wrong with you? You get put in the psychiatric bin. And then it's very, very difficult to get treatment after that. And none of it's reparative. And that's where hyperbaric oxygen stands out.
Well, but to be more specific of my earlier comment, I was with a group, and Jim Hooker, you brought Jim, was with us, and Simon LeMay, who was a sergeant major and significantly helped, went from suicidal to full executive function. And we're in front of the chiefs at the Durham VA facility, and the chief of chiefs, who was leading their group, the three of them, could not admit that a traumatic brain injury caused any type of inflammation. And the biggest insult that he delved out was, have there been any animal studies? And so,
Okay.
we know that in severe cases, they actually put a pressure gauge, into the skull
Yes.
to monitor it. So,
Yeah.
so to me, it goes back to why it's a rice bowl thing, because these veterans are loaded with bags of pharmaceutical drugs
Yeah.
and billions of dollars being paid for that. And when you see these veterans getting the hyperbaric treatments, one of the first things they say is, I'm off my drugs, and
That's what we published in our veteran study. In fact, it's the only study that's shown a reduction in suicidal ideation.
hyperbaric oxygen.
Correct.
Yes.
And it's in the study there, in black and white print on top of it. 68% of them, I believe it was, decreased or discontinued their psychoactive medication during the study because they felt better. And there were another 3 or 4, I believe, who stopped all of them, unbeknownst to me. We had told them, you stay on everything you are, we're only changing one thing, you're getting hyperbaric oxygen. They then told me later, well, I stopped all my medicines, the day before, the week before I came down.
They
For the
did. They were
study.
also afraid that they were going to lose their disability if they didn't
Right,
follow
right.
doctor's orders.
I forgot that.
And the doctor's orders made
Yeah.
them zombies on all those meds. They would come in
Right.
with a gigantic Ziploc
Yeah.
with all their medications, because you couldn't even write it all down on a list. They just
Yeah.
dump it out on the table. I mean, it just,
Which if any of us were taking, we'd be comatose here right now. I mean, it's just a huge amount
yeah.
of medication.
So is it fair to say that inflammation is going to shorten and eventually end our lives in some form?
Yes.
So the most powerful
As a
anti-inflammatory...
contributor, there are many things, but yes, the inflammation, long-term is that grinding, slow process that...
I use the
takes
term
you-
influence. It's going to influence the
Yeah.
end of our life.
Yes.
And so why not take advantage of the most powerful anti-inflammatory that's God-given to us? And I think just to conclude the segment, because we're going to open up to Q&A, we do have a great audience here in our studio. And this is the first for us to have an audience in the studio, is we've just, the tip of the iceberg in this short talk.
Yeah.
But we cover the spectrum from longevity, children, a lot of brain issues, burns, skin, everything in between. There's a lot to learn. And I think for the spirit of humanity, we need more people involved, and we need to move forward with this. And I think the people, the patients, patient advocacy for your family, as Julia brings up, the veteran, the families. What do these childhood brain injuries do for the family?
Oh, it
There's
just destroys them.
so much suffering for
Yeah.
that
It just destroys them.
that
And kids playing sports in high school, parents don't know that the football and the soccer and the multiple hits to their heads is causing damage. It causes changes in personality. Some kids go from being A students to C students, then they're hanging around with different kids because they can't keep up with their friends who are A students. And this is not looked at all.
So everyone needs to understand that it's important to get involved. Look for hyperbaric
Yeah.
oxygen, and let's make a difference. Let's save a lot of lives and
Amen.
improve a lot of lives.
We will, and indulge me with just one more anecdote. I'm going to blame it on you because you brought it up, this, animal study thing. The 3rd year I presented this to the Medical Society's scientific meeting and had this unequivocal imaging evidence and such. The doctor said, well, it'd be more believable if you had an animal model. Now, these were chronic cases, years unchanging. And I was naive and
Yeah.
new to this game. I said, oh, okay, I'll go do an animal model. Well, you go do an animal experiment, you have to put it before an animal use and experimentation committee, and you have to do a literature review that looks at all the medical literature to find out if somebody's done before what you're trying to do, so that you're not just wasting animals. And when I did that, we were shocked. We could find no publications in the history of science where someone had attempted to treat a chronic brain injury in animals. None, zero. So I applied the human protocol, I hate that word, but the human dose that we were using to the rats and got statistically significant improvement in memory and cognition and an improvement in brain blood vessel growth. And in the article in 2007 it says, this is the first improvement of chronic brain injury in animals in the history of science. Nobody challenged it, and today that still stands.
So I wish I would have had that ammunition with that psychiatrist.
Exactly.
But as I understand, science it starts with small animal, large animal,
Yes.
Europeans, and then
Yes.
Americans.
Yeah, that's right. Exactly. If you don't kill and maim the Europeans, then you bring it to America and you do the real studies, and then, it's believable.
Well, so-
And here we were doing it in humans. We had to go back and do it in the animals. It was just a joke.
So millions and millions of humans benefited from this, and so now we just need to do it. Like,
That's what this is about.
safe and effective. So
Yeah.
how about we open it up to some questions from,
Sure.
from our audience?
All right.
So if you have questions that you would like to ask, if we can just have one person at a time come up here to the microphone and the H button is set, that way our viewers can also get you guys on the live stream.
Dr. Harch, I just want to say to you and your wife, on behalf of the North Carolina veterans who have benefited from oxygen therapy, we are very grateful for your profession, very grateful for your contribution. It's been very special in a lot of respects, and it's been especially special in my life. And the result of that has been very special to the state of North Carolina. And we're grateful for all of your experience and the many, many patients that you treated and all of the extraordinary stuff you just talked about. I'm kind of focused on this problem that we have with the United States government. And in particular, it has to do with what you were just talking about earlier, in that we're looking at TBI and PTSD as mental disorders under the DSM-5, as you know, the Diagnostic and Statistical Manual of Mental Disorders, instead of treating them as an injury. And my question has to do with that, and it goes like this. Given that the VA and the DoD leadership know and understand that HBOT heals injured tissue, and in light of the VA's mission to return the wounded back to the state from which they came in the best possible condition, what would be your view of why they are so resistant to using HBOT for TBI and PTSD?
Well, it's some things that I alluded to earlier. The history of this has been a lack of understanding of this therapy. And one of the problems has been the hyperbaric medicine physicians themselves and their influence through the medical societies with the federal government. The people who, when the first idea came up about hyperbaric oxygen potentially helping a chronic neurological injury, it was with my mentor, Dr. Richard Neubauer. But it was a time when the hyperbaric medicine field was in its fledgling state in the United States. They were fighting for credibility and for reimbursement. And part of the problem was Dr. Neubauer stood up and showed that we could maybe treat a chronic neurological injury, which, number one, challenged and violated a central kind of dogma of the neurology specialty. But the bigger problem was he could do it for about 1/8 the price in an outpatient clinic. And this was being reimbursed now, and they were fighting to get it reimbursed in the hospital setting at 8 times multiple of that. And so this was a threat because it also now brought in the resistance of the neurological community to what the hyperbaric doctors were trying to do. And in the process, he became public enemy number one of hyperbaric medicine. And the disparagement of him and the science he was trying to espouse, well, that's now become embedded. And it's this financial component for one, and that we are many years down the road, and despite what is really unequivocal evidence now, we now have the problem of how do we rectify the past to stand up and say, oops, we were wrong. We were wrong about Dr. Neubauer. We were wrong disparaging this. We have denied the opportunity for so many people. We've obstructed the advance of this. We're sorry. There's almost no retreat there. And the science is now showing that their definition and the whole foundation of this therapy is wrong. It's almost insurmountable, not completely, but it is a major obstruction to this. And unfortunately, it is the government that's reliant on this group of hyperbaric medicine doctors for their policy decisions. Now layer onto that the studies that were improperly designed with control groups that got a dose of hyperbaric therapy, pressure and oxygen, just like the cerebral palsy study, and lo and behold, it was bioactive and it worked. And so they haven't been able to reconcile and explain this, let alone excuse it. In March, I published an article that is now a systematic review of all of this evidence for traumatic brain injury. It is unequivocal that this is beneficial, and it meets the highest criteria. And in there, all of this is discussed, and that needs to be the foundation going forward for the advancement of this, because we have the evidence, we have the arguments, everybody wants to rely on the science is there, it can't be refuted. But in the process, there's going to have to be an acknowledgement that the past, things were wrong. And it is only through dissemination like this and open public forums that this is going to be identified. Because one of the prized researchers that did one of the DoD studies, in fact, proved that this worked. And he has now stood up and said that. But they haven't taken heed of it.
So I would say conspiracy theory no more. It is a conspiracy. They've worked together and conspired to stop it from going forward. And that is sort of the negative view that I say the rice bowl theory. But people have stopped this. And you brought up the 8 times, what Neubauer was charging was a threat. And so they came out and they stopped the threat. I don't think it was that complicated. You're very kind to think that there was much more science involved, but I think that it was obvious. It's obvious to
There's
an
more
engineer.
politics involved.
Yeah.
There's more personal items. There's more ego. There's just a lot of ugliness behind it. And the root of it is a lot of this misunderstanding. What this does is challenge the entire 60-year basis of this therapy and their dominance and their consideration. They're the gold standard in this field. And it's a house of cards by their argument. The science is there. It does work. There's no question about that. It's how it's been interpreted and explained. And so now we're at the threshold, and I didn't tell you the denouement of this, which may not be. It's just another step in the process. I put the new definition in front of them and their journal, and they have rejected it, not on scientific grounds. And so it's now been published. It is going to be published within the next few weeks in another hyperbaric medicine journal, peer-reviewed, respected, etc.
And can I say something? So it's also very difficult for all of these old doctors to do an about face and to say that, sorry, we were wrong.
Yeah.
They just don't, yeah.
There's liability as well, potentially.
As you said, Dr. Harch, medicine progresses as
Funeral by funeral.
That was Max Planck.
Max Planck.
one doctor at a time.
Yes.
Mm-hmm. Let's see.
And it's true, because it's hard to teach an old dog new tricks.
We have another question.
All right, yes, I'm sorry.
Thank you. Thanks to everybody here. Really look forward to getting to know you a little better, Dr. Harch, and your team. I think my question's kind of unique. I was born and raised in D.C. I'm 58. I think my telomeres, which Ed is going to work with me on here in the coming weeks and months, I think my telomeres are 78, so I'm the exact opposite of Mrs. Harch. But here's the reason. I've been addicted to tobacco. I've been addicted to alcohol. Been addicted to cocaine, opioids. In my past, I'm seeking help for some of it. You see the look on my face. I'm living a good life right now. But after reading your book, explain what I think I'm going to see from Ed when I come up here about my tired brain.
Your tired brain's going to be less tired. So, I mean, it's just, again, I'll take us back to the basics. Has your brain been wounded? Yes. All of that substance takes a toll. Go to one of the congressional hearings where I presented these cases, and a case, and I showed it in lectures, of 68-year-old guy, alcoholic for decades, but brilliant guy, very productive, extremely wealthy, made a lot of money in the business, the tech business and all, but he damaged his heart. Heart was now in atrial fibrillation, the atria, predisposes to forming clots unless you're on a blood thinner. Well, if you're drinking, you don't take your medicines, and he stopped taking his blood thinner, got a clot, got a stroke. And of course, on his private residence on his island, they couldn't get him to the hospital in time for the clot dissolving drug. So a month later, a colleague of mine, neurosurgeon who was a friend of his, referred him, and he came down, and I treated him, and it's a shame his sons won't let me use the video. It is just a dramatic effect, but I imaged him, and what we saw, and I didn't know it, the whole month I was treating him, he was drinking heavily. Despite that, he made this remarkable improvement. And on the imaging, what you see is the effect on the whole rest of the alcoholic brain. It affected his stroke as well. And now, I mean, I've treated countless people with substance abuse injury to the brain. Interestingly, SPECT brain imaging, what is one of the uses of it that was originally cleared for, but with stroke, dementia, and they showed it with cocaine effects in the brain. Well, seizure disorders, but one of the demonstration videos is about the effects of cocaine on the brain and how you could image it with this modality. So what I've treated is a large number of people now with wounding of their brain due to substance abuse. And this has a regenerative capacity to it, such that you can reclaim lost reserve capacity to varying degrees, and depending on how long you do it and how much and so on. We don't know whether you can kind of Benjamin Button this situation to some degree. You can. We know that. It's how much.
I'd like to one quick follow-up. Should I come see you, or is it okay to see Ed?
Well, if we start with the rice bowl thing, you're here. Go see Ed. Ed, go see Ed.
Hi, Maureen.
Good afternoon. Thank you so much, Dr. Harch. I have a question because I've had a heart transplant, and as you know, I take immunosuppressants every 12 hours, and I'm concerned that if I ever wanted hyperbaric oxygen, that would interfere with the suppression of the immune system. In fact, it might cause a rejection of my heart. Is that the case?
We don't have any evidence of that. And hyperbaric oxygen is immunomodulatory. It essentially affects an immune system that is dysregulated. So the overactive immune system, the underactive immune system. You've got an artificially suppressed immune system. This could be healthy for your immune system, but it can inhibit rejection. Right before Hurricane Katrina, I had a project with a doctor with the main transplant organ service at one of the major academic hospitals in New Orleans. And I was treating 4 lung transplant patients that were all showing chronic rejection. And it was a complicated thing, but clearly 2 of them had a suppression of their rejection. Now, you are not having rejection, but to activate your immune system to reject you, I don't know that that's been seen. And we've treated a lot of transplant patients, for instance, kidney transplant patients who are diabetic, for diabetic foot wounds. We don't see their kidneys rejected.
Okay.
So the evidence would be against activating your immune system to reject your heart.
Thank you.
Well, I don't know where to start.
Anywhere.
We met in 2008-9. I was the director in North Raleigh, and you were doing the DOD. I've communicated with Duncan over the years, and
What's your name?
Who are you?
Dr. Stevens, James Stevens,
Okay.
and and I've had my own battle wounds. Right, medical board came to me and said, cease and desist. I am now with Ed. I've been Ed. It said, approach me. How many years ago?
So 8.
But I want to say, hey, thank you. I'm an apostle. Right? There's nothing that you've elucidated that I'm not a big believer in. I have a private practice. I'm a chamber of 1, up to 2 atmospheres. Okay, but I think the questions that I have probably are questions that you've entertained at the podium back in Colorado, down in Charleston, which is the controversy around dosing in concussion.
Yes.
So I started a sports medicine practice in this town. We have 65,000 patients, 15 providers, and we do about 1,000 concussions in this county per year, visits. And it has been an extraordinary hurdle to try to bring even my junior partners over the fence. And the question comes up, what's the dose? How many treatments, right? I've been very impressed over the past few years with some of your position on low dose, right? Pressure, 1.3, 1.5 can get it done. But we're all looking for, right? And it sounds like what I'm hearing you say, you got to get in the game and then you just have to take it one patient at a time. Everyone's a little different.
True, but still, you can't look at somebody and say, you'll be a 1.3 air with a little supplemental O2. You're a 1.5 of O2. You're a 2.0. You don't know that. And of course, where we started with this was exactly that, trying to find, first of all, if this therapy could affect any brain-based neurological condition. And got to have one variable. We just chose and looked at one dose for which there was precedent treating acute severe traumatic brain injury and stroke in Germany. And then my mentor who had used it for stroke and some other conditions, and there was the MS literature suggested it from that study at NYU in '83 that while they gave 2 atmospheres when they measured the blood level of oxygen, in fact they were getting somewhere around maybe an atmosphere and a half. And so was there some magic to that? So that's where we started. And everybody got the same thing. And what we found was our treatment time was too long for some patients. Certain diagnoses did not show and were very sensitive, and we got some side effects and so on. And so, I've still struggled with, in the process and the Bayesian practice of medicine, you do that, it works, okay, you keep doing it. Oh, it didn't work there, so we got to change something. And it alters how you do it. I did get a feel, if you will, but it still is not exact. Until now I've been working on this the last 3 years, and conceptually for some time. So when we would do the sequence of scan, put someone in the chamber, rescan them. That second scan was 3 to 4 hours after they came out of the chamber. It was the delayed effect of what happened in the chamber. But I could never look at the brain in the chamber. What was happening under that pressure and oxygen? Now I can. And what I've done is adapt quantitative EEG to where I can do it outside the chamber and then in the chamber, and take the patient through a multi-dosing profile of different pressures, oxygen levels, mixes, etc., and look at the brain live, record, and then have it quantified. And it's now given me a new starting place where I can see the brain more optimally functioning in a given range. And while the answer's not completely in on that, it's been a good guideline. And it also, we're going to publish this, but it's the obvious refutation of the Department of Defense studies where the placebo air pressurization group we're now showing is so bioactive and beneficial to some, not in others, you know. So we're getting closer, and the science is there to argue for this. So think about this. I mean, really, the evidence is there for hyperbaric oxygen in acute severe traumatic brain injury. In fact, this multi-center study, I don't know how they got it passed ethically, because the evidence shows even a few treatments in that setting in the first few days reduces the mortality by 50%. Hard science, not refutable. And it's even been shown with some randomized trials in subacute, moderate to severe chronic brain injury. And now we've got it in mild, persistent post-concussion syndrome. Why wouldn't it work for acute concussion? And we've actually done that, starting back in the 90s with patients, and half those patients are my family members that have had concussions. And of course, you know, Daphne Denham has treated now hundreds of patients, and others have. There's a common experience there. But the acute concussion study is difficult to do, and it has to be structured a certain way. And I had the same problem convincing our pediatric concussion group and trying to show them how this could be done. So it's an argument, and in fact, one of the studies was just done in North Carolina here. But if you look at it and the design of it and so on, they were never going to have a chance of proving that. I mean, essentially in each group, they got 2 or 3 patients. You just, you know, it's difficult that way. But there's a way to do it, and it can be done. And if you've got that volume, it's just waiting to be done. And there's even a middle ground where you can shoot where you have the best chance of seeing that, and it's not tricky.
Well, I would thank you, because the rest of us without multiplace and multimodalities like specs, and that we really are rowing the canoe behind you.
Well, okay, thanks, but let me point something out. All of this work I've done, all of it has been done in monoplace chambers in a freestanding clinic. I've not been able to do any of this at the university. It's my appointment at the university, and our site becomes the university affiliated site. All of it's been done in monoplace chambers. Yeah, the critical care and other experience we've got in the diver that we talked about, resuscitating and all that stuff, yeah, it has been done in a multi-place chamber.
Can I switch gears?
What's that?
Yeah.
Yeah. Oh, sorry.
Well, I'm 67.
Yeah. Same here.
and I try to dose myself on a regular basis. But there's been so much that came out of Israel in the last few years. And sort of the anti-aging, you know, wash over here has been, I want to be part of that trend now. I want to be part of that trend.
Yes.
Which has led, you know, and I have a very small, you know, very hands-on practice. My clientele says, can I put one of these in my home? And now you start to get into that movement towards, right, who's going to do it? How is it going to be overseen? What does the dosing look like, et cetera, et cetera? Comments?
Well, yes. As I talked about, in the process of doing this and trying to look at fixed dose and finding that, it was too much for some things, in particular like the drowned children. You know, it seemed like they may be more sensitive to a lower dose and so on. I had gravitated towards changing the dose in different conditions, and even looking at it with SPECT and so on. And then, but the problem was, I'd done all of this work with oxygen, and when patients come to see me, they want the oxygen. They wanted what worked on somebody else. And so I had a lot of trouble, especially, you know, people come from all over, and if it's a big outlay of time, resources, everything, and you know, they want a certain thing that I had shown worked. It was hard to convince them until that little drowned girl, Eden Carlson, and I'm not
Robert
speaking outside,
Robert Boyden.
and Robert Boyton and others whose names, and we have permission to talk about them and all. But that little girl, you know, the reality is after she was dosed and treated so successfully, was she 100% normal? No. And it's a devastating injury. How do you continue that treatment? Come back to New Orleans every so often and live there and so on? I mean, it's prohibitive. And so it turns out she was responsive in that low dosing range that could be achieved in a portable chamber. So I transitioned her to a portable chamber. Now I've got a few hundred patients I've done that with. And I
But let me
oversee
clarify.
their
The
treatment.
portable chambers, the 1.3, not any deeper than that, just
Fair
just
enough.
wanted to
That's
Yeah,
fair.
clarify that.
so
Yep,
it's,
yep.
yes, but I help manage them, teach them how to dose and treat their patient. Now, there's a little risk there. I mean, I'm dependent on them staying in touch with me and all, but, you know, in the interest of trying to get these kids and adults and so on to a higher level of function, I've, you know, accepted there's some risk there, but I transition them, and it goes back to the science. Is pressure and oxygen bioactive at those levels? Unequivocally, it is and can be. And so that's the way I have dealt with this, and it's working out.
But
And
Dr.
others
Stevens,
aren't.
a minute ago, when you asked the question, were you asking about the hard shell chamber?
All of the above.
Oh, hold on.
Yeah.
Because the hard shell chambers, there have
Okay.
been deaths in the chambers,
Yeah.
and not our patients. You know,
So-
they call, we seem to be the call center for problems, and, you know, they're not our patients, you know, they call to talk about it, to complain, to
Yeah.
ask what went wrong.
Sure.
So I can log a lot of mishaps. I want to clarify, they're not our patients. We had nothing to
No,
do
I
with them.
understand. Yep.
So there
Thank you.
have been deaths,
Yeah.
and absolutely, positively not, unless there are trained medical personnel with an MD watching over what's being done. There's huge liability, and there's risk of people really, really hurting themselves.
Thanks for bringing that up.
It's not a
Yeah.
tanning bed. People think
So-
it's a tanning bed. People think it's as simple as, you know, going to a spa and going into a tanning bed, which a lot of spas have done the disservice to hyperbaric oxygen by putting portable chambers in, and nobody's watching, and nobody's trained, and nobody can answer questions. So, go ahead, you take it from here.
So what happened is this got, you know, kind of publicized, and I was presenting this stuff in the 90s. By the late 90s, I was getting phone calls from people around the country. I took my child and got hyperbaric treatment just like you said it worked, and it didn't, and now my child has this problem. Or my husband, or whomever. And I said, well, hold on, wait. And I'd slow them down, I'd get out some paper, and I start taking notes. And in 1999, Dr. Neubauer asked me at the 2001 symposium that was put on there in South Florida. He didn't want me showing all this brain imaging I had, because I had such a good scanner, and he had a single head one, and, you know, the rice bowl and competition anyways. So he thought he'd give me this topic of the dosing of hyperbaric oxygen. Dose of hyperbaric oxygenation as a kind of innocuous. I said, Dick, you're not going to like what I'm going to talk about. I said, you know, there are people getting hurt with this. And I collected the cases. It's in a book chapter. It got published. You know, unfortunately, it's out of print now. But while we were doing the formal experiment, I documented, started seeing some side effects there as we were getting up in treatments. And I went running, and at the Gulf Coast Chapter UHMS meeting in April of 2006, I presented 5 of these cases. I said, what is going on? Because it's written in, it was dogma, dictum in the field that under 1.9 atmospheres of oxygen, there was no such thing as oxygen toxicity, oxidative stress, overdosing, no such thing. So here we were in an atmosphere and a half, there was no such thing, sky's the limit. We could treat as long as we wanted. And here we got up in the 65 treatment range, and people were having these side effects. And what is going on here? I went literally running to the meeting. It turned out that year it was in New Orleans. We had 110 hyperbaric doctors in the room, and I showed these cases and these symptoms. They looked at me like I had 3 eyes. Nobody had seen this. Well, nobody was really looking or paying attention, but it was oxidative stress, and we altered what we were doing. Now we started getting all of these patients calling in. Well, I put this under LSU's IRB to retrospectively look at it, and as time went on, there were more, and now there are 3 deaths with parents that put hard shell hyperbaric chambers in their home and treated their kids. And
Those are the ones we
they-
know about. There's probably more that we don't know
Yeah,
about.
because
Those
the
are the
one
people that called
guy,
us.
the one guy was this engineer from local who had a child, and he called me up, I don't know how many times, asking me all these questions about the science of going over and dosing and this and that.
But you
and
didn't know
was-
he had a chamber in his house.
No, and he was gonna bring his child down for me to treat, and then I didn't hear from him. A year later, he called me up and asked me if I wanted to buy a chamber. And I said, buy a chamber? Whatever happened to you? And he told me the story. He bought a chamber, had it installed in his home. The child had seizures, traumatic brain injury, and he treated, and the seizures went away, and the child got better. And he kept treating. And the seizures came back. Well, I had treated seizures successfully, so hyperbaric oxygen is good for seizures. He kept treating, and he kept treating, and the seizures got worse and worse and worse. Finally, the child died of seizures. And there are 3 of them now, like that. And so, and we've now even documented this in portable chambers, people sleeping in them and prolonged treatments in them and so on.
I think the
You
professional
can-
sports, you've seen that, they've made that, they popularized it.
They have. And see, the problem is, where do these people talk about their problems and side effects? They don't. They just kind of slink away because they went above their doctor's objection. They went and got that therapy that doesn't work, and now they feel guilty, to blame. And this is exactly what happened in Florida 3 years ago now with a little drowned child. That mother had called us up, was going to come, thought, oh, I'll do a little local shopping, and found this place in Delray Beach, Florida, operated by a physical therapist. And they told, oh, they worked with me and consulted with me frequently and so
Lies.
on. And it was a mother in my waiting room who
Never.
came in and said, a child died
One
of
of your
yours.
patients,
One
she
of your
said.
patients died in Florida. I said, oh, what is going on here? Well, on Facebook was this whole interaction that they worked with me and consulted with me. The child was on a ventilator. They took the kid off the ventilator that the parents were managing at home, and they gave the dad a bag valve mask to give to the child in the chamber, put him in there, and walked away. 5 minutes later, the dad is knocking on the chamber. The kid is turning blue. And the physical therapist came over and looked. 2 thumbs up is what it said in the Facebook thing. He gave us 2 thumbs up
And
and
walked
walked
out of the room.
away. Another 5-7 minutes later, this kid is stone cold dead and blue. And rather than bring the child out, they brought him out on an electronic decompression, another 7 to 10 minutes. And of course, the child was dead. Well, this didn't get reported to medical authorities, the Department of Health, anybody, because what was the mother's post? The mother, I killed my baby. I took him to this place and I did this, etc. It was, mea culpa. She took it all on herself. But this was total mistreatment. This was so grossly wrong. So it doesn't get reported. And we've actually reactivated this IRB now. The application is in, and I'm really compelled, but we're going to put this out there to show that, this isn't innocuous, that you can get to a point of harm. So that, I think, covers the home chamber, hard shell, soft shell, but,
Well, still with soft shells, I mean, it's a 1315. I've been following your argument for 8, 9, 10 years. And even in that low dosage, how long do you go? And
it depends on when you intervene. And it also depends on the diagnosis. So these drowned children, the ones who come to me 3 weeks, 6 weeks out, they don't get 40 treatments, and they can be exquisitely sensitive to oxygen. In fact, I've had children at 1.3 atmospheres of air, even 1.15 atmospheres of air, that cannot tolerate it. They increase their storming, they can have more seizures, and so on. So, I mean, you have to be more careful depending on type of injury and all. But what I've done, I look back on where we started, almost glibly, based on this dictum that there was no such thing as injury. And when I presented these 35 cases, the first group of which were ones that we were doing on the experimental protocol and got up in numbers of treatments, and then all the rest of the call-in cases, you would have think I had screamed fire in a firecracker factory at that symposium. The doctors in the room and Dr. Neubauer were just angry with me that I was suggesting there might be a limit to what we could do, that there were side effects. But it's very real. And so it's a medical practice issue,
Correct. Yeah, and I
That's
think
what it
that
boils down to.
I think
Yes. I just want to say, and the benefit of going slow and steady, at a dose where the patient is responding to it and knowing when to stop and when to give a break, is that you can treat patients for years, meaning that there's no limit to healing their brain. If they get oxygen toxic and the provider doesn't understand the signs and symptoms and they keep treating them, there comes a point where they can never get hyperbaric oxygen again. So they're stuck at that level of healing. So with some of our patients, we have been healing their brains for 5-6 years,
Sure.
and they're still getting better.
Yeah.
Because it's slow and steady without oxygen toxicity.
But I tried to start in a lower range, especially with these children, and then I can explore the range. And it's a conversation with the parents. Look, I can't tell how your child is going to respond, but we're going to be very careful here, and we're going to look. And actually, so many of them are demanding that they want, more is better.
They don't
the kind of
understand
myth.
that less
Yeah,
is more.
and so that's a lot of the
Right?
discussions,
Yeah.
yes,
Less
that we
is more.
have. To kind of tiptoe through this thing. But again, it's a practice of medicine issue. And you try to find, that's why the QEEG now and the live look at it gives me a starting point. But the kids are tough because they're not cooperative.
Well, there's so many medical specialties, so you have a gastro issue, you go to the gastro specialist, right? So you have the opportunity to get hyperbaric oxygen. You need to go to a doctor or a medical clinic that has that experience. You don't just buy a chamber and jump in it and think that you know what you're doing. So there's the risk, right? I think.
Yeah.
That's the point.
Dr. Harch, are you familiar with the WAVI?
With what?
WAVI testing? It's
WAVI?
W-A-V. It's a cousin to the QEEG.
Is that a brand name of one
Yes,
of
it
the?
is. Right.
No,
It's a head unit. It measures electrical activity before, during, and after, in an effort to try to follow what you were just describing. That's really been my approach recently, is to try to see what's that brain telling us? What happens after a certain dosage? And then, of course, subjectively, patient or parent, what are their responses? And going from there. But it always feels like, how do you ultimately know?
Again, it's clinical practice of medicine. People always like to ask that. And we just had this discussion earlier, I think with Melissa, about looking at outcomes for traumatic brain injury studies, or Jim Hooker asking about it. If you look at the way we try to look at these studies, I designed them to try to appeal to everyone in the neurological community, neurosurgical, neuropsychological, doing, what are accepted proofing instruments that you could use. But when we went to the FDA, what did the FDA want to see? They didn't care about the imaging. They didn't care about EEGs. They didn't care about anything else. What they wanted was a broad-based symptom questionnaire. And I was floored. They told me what they didn't like, and I finally turned around and I go, look, guys, I don't care what I use. You tell me what you want and what you'll believe and accept. That is the only thing that's important. And it's like, oh, okay, well, well, we would tell you we would like to see a symptom questionnaire. So now if you go to the study by Dr. Lynn Weaver, the BEMA study, look at the conclusion. In the last part of the conclusion section, they looked at everything. Neuropsychological testing, imaging, sleep studies, balance testing, inner ear function, everything. And at the end of the day, the one thing that registered, improvement or not, was the symptom questionnaire that the FDA recommended that we used, that they then put in their study also. And when you get right down to it, it's really the basis of the practice of medicine. What do we do? People come into our offices, they've got complaints. It's symptoms. And you read of them physically and physical exam, are they sick, are they not, etc. And when they come back after you've treated them, what are we looking at? It's symptoms and the read and so on. So it's a practice of medicine issue. It's the foundation of medicine. And so the academics, yeah, well, did you measure this and that? Yeah, well, we did, but we also showed it with symptoms.
Well, the impact you've had, I'll give you one other example. I've been in the professional sports world for, this will be my 26th year. And for 24 years, right, concussion, you know, the old adage was, I'll go to a fight and a hockey game will break out.
Oh, yes.
Right.
Yeah.
Now I get a call. Now I get calls. And the challenge for me is a high profile, right? There isn't an easy prescriptive, right, that we'd all agree. Is it 5 visits? Is it 10 visits? Is it 3?
It's to symptom plateau. Again, it's a practice of medicine issue. Someone's all better, or they're saying, hey, I'm better. You don't keep pounding them with whatever therapy you're giving them, or, you know, keep the drugs going on a long-term basis. You may not need it, you know, especially for an acute injury like this.
Yes.
And the reality is, if you get them soon enough, within, you know, 3-5 days, vast majority of them, it's 2-3 treatments.
Yeah. Yeah.
And in that pressure range, there's kind of a range there where they're responsive. And it goes back to the German studies where they looked at dosing in acute severe traumatic brain injury and acute severe stroke. Brain is sensitive, you know, in that pressure range.
I helped participate double-blind randomized with UNC, Dr. Jason Mihalik, in an acute concussion. And it was the medical board that shut down that clinic back in Raleigh in those days that stopped us from what was grant funded, 160. We never got past 12.
Yeah.
But it was five sessions based upon that short acute injury.
Yes.
And well, we'll have more time. I thank you for
Yes.
everything you've done, and you certainly have inspired me along the way.
My pleasure.
So we have time for a few more minutes. Any questions in the audience? I'm happy to answer those. No, I'm good. And so,
Yeah, I had a question.
Oh,
Here you go. There you
Thank you very much, Doctor.
go. Oh,
I appreciate your words today. It's been quite elucidating and very encouraging to hear about all the different ways that this treatment has benefited many different people. I just appreciate the years and the study that you've put into this. I've had some concussions, and I've been dealing with them for several years now, and have really tried everything out there that you might think of. And out of everything that I've tried, I will say the hyperbaric treatments have been the most effective of anything. And I have attempted to try different other things to pair alongside hyperbaric treatments, such as fasting. Here at Extra Vita, in the wintertime, we'll have like the what we call the longevity challenge, where like people will fast for 2 weeks at a time and undergo a number of treatments. And I've found that fasting while doing this has been particularly effective as well. It just feels like my brain comes alive in a special way, and it's like, I don't know, I've never felt anything quite like that. Would you suggest anything else to like pair alongside hyperbaric treatments similar to fasting, or would you have any thoughts about fasting in conjunction with hyperbaric treatments?
well, fasting is kind of a hormetic stress. You're turning on some of these survival genes and all. It's also changing and probably minimizing the amount of sugar in your diet, obviously, for 2 weeks or however long you fast. And those all have beneficial effects. But the other things that have been effective in my experience, or there's evidence for them, is photobiomodulation, light therapy, with either diodes or laser, is showing some effect in people with traumatic brain injury, and may have some common pathways with hyperbaric oxygen therapy. EEG neurofeedback is another one. And so it's one of the most frequent things that, even though I have the equipment and all, I'm not trained in that, and I don't offer it. I'm just, we answer the hyperbaric question. But after you have changed the brain with hyperbaric oxygen therapy, EEG neurofeedback, after you change the brain, EEG neurofeedback trains the brain to use most efficient electrical pathways. And it can be very helpful in traumatic brain injury. And those are the two main ones that I recommend to people. Stem cells always come up, and there's a Chinese study showing in acute, I think it was moderate to severe traumatic brain injury, and a stem cell administration, and then outcome measurement a year later, and they claimed a difference in outcome between the two groups. Hyperbaric oxygen therapy, as it turns out, and as we talked about earlier today, if you go to the Team Luke Hope for Minds website and the lecture I gave on hyperbaric oxygen and stem cells, hyperbaric oxygen affects the stem cells at every single step in the process in our body. So how much more exogenously administered stem cells, i.e. IV or whatever, can help? Not as certain about that. But those are the two main therapies. Can you think of anything else?
MCT oil?
Well, yeah, MCT oil, of course, is part of what the whole
Omega-3?
ketogenic diet is about. And
Certainly.
what fasting kind of is getting to. It's burning your own fat. Omega-3s, yes, I'm not so convinced and knowledgeable about the actual research that's showing benefit, let's say, in traumatic brain injury. But your hyperbaric treatment, even on a longer-term basis, can continue to be stimulative and helpful.
Thank you very much. I appreciate it.
Thank you.
So, one of the topics that Dr. Stevens maybe could add to this was that he mentioned that when you're fasting, that your body's producing more stem cells, as well as the hyperbaric oxygen. And is that?
I didn't know that.
That's true, right, Dr. Stevens?
I didn't hear what you said, I'm sorry.
You had mentioned that with fasting, that your body's producing more stem cells, that when you're fasting.
You activate stem cells, ketones as well, ketogenic diet like you mentioned. HVMN is a company that did some DOD work with ketone esters, which are rapidly absorbed. And they worked with special forces for a few years and had some significant success with ketone esters, at least temporarily on a daily basis. It was brain clarity and focus and stamina.
So to that point, with the hyperbarics together, you have all this clarity, and I sort of joke, is that why you're fasting? You seem to notice every little creature that goes by because you're so hungry. That you notice things you don't normally notice.
Hi, Doctor. Thank you so much. I've really enjoyed it. I have so many questions, but I'm going to try to stick to a couple of them. And really, it's around well care, because of course, in the medical world these days, everything is pretty much around sick care. It's around taking an approach for people who have already suffered either a traumatic injury or some of the other things you've discussed today. So I was a professional athlete for many years, a runner primarily. I'll be 60 years old next month, and I had concussions when I played football in high school. I had a few concussions throughout the years, mountain biking and falling off other things, and nothing for a number of years. I also have a history of Alzheimer's in my family, so there are these things speaking to me at this point, in my life as I start slowing down some physically. Although I run very long distances. I'm still extremely active. So for me, I'm quite interested in how this can help me as a person who's not dealing with anything in particular other than the fact that I want to be healthier. Interestingly, just to finish up the thought, so I'm partners with Deepak Chopra in I've been clean and sober for 30 years now, so I love the question that came earlier. And so another part of my history was as an addict and an alcoholic in my 20s, and I'm happy to say that's well behind me. I've spent a fair amount of time with David Sinclair, and we've had some debates around longevity, and I give him a bit of a hard time about the fact that he wants to give me a pill, for $10,000 to help me live longer. And I always say, well, what about movement? What about physical movement? How about, you get out and actually move your body and all that? And I understand his point of view, and I admire his research and the things that he's doing. But so the question buried in all of that is, for someone like me, who just wants to be healthier and live a healthier life. I'd rather live a healthier life necessarily than a longer one. Both would be awesome. But like how this can help me.
Well, I just ask you, you got a lot of mileage on you, literally, right?
Indeed.
And have you wounded your brain? Have you wounded your body?
There's pretty much no doubt. I mean, a lot of sleep deprivation too.
So, and I think we touched on this a little bit before. Our body has redundancy in it, every organ system. You have 2 lungs, take one out. You're going to have trouble doing your long distance running. You're going to have trouble in Denver, Colorado, etc. Got 2 kidneys. You can lose 40% of your left ventricle of your heart with a heart attack. You'll still survive, but you're going to be compromised. You lose that reserve capacity. The brain is no different. So alcohol, tobacco, addiction, whatever, takes some toll. Now, you modulated that with all your aerobic exercise and other fitness and so on, but I'm sure there are other things in there. You've had concussions as well. Study done in 1980 by Dr. Ewing, neuropsychologist. 2 groups of college students. One that had had a mild concussion, but marked by transient loss of consciousness 2.5 years before, but were now completely asymptomatic in college doing their work. Matched to another group, no concussion. Neither group with any other neurological disease. They did some cognitive testing on them, and the 2 groups were matched. Put them in an altitude chamber and took them to 11,800 feet, Leadville, Colorado, equivalent to essentially, and had them repeat the testing. And what happened? The ones with the previous concussion had about a 10% or so reduction in performance. And we know, by the way traumatic brain injury is, you don't completely repair that damage. You're damaging the white matter, so you lose some of these white matter tracts. Well, what happens? The residual ones sprout to try to take over the lost connection. So what do you have now? Reduced bandwidth, sending the same amount of information over lesser tracts. And where do you get compromised with that? Stress conditions, sleep deprivation, hypoxia, whatever.
Multitasking.
Multitasking, exactly.
Being in an environment where there's a lot of activity, like
Kids.
the mall on a Saturday
Yes.
morning with kids screaming, or an amusement park with the music,
So the residual, the signature is still there, not completely repaired at all. So at your point, we are the sum total of everything that's insulted us all those years and whatever we've done to kind of ameliorate it, your running, your activity, your healthy living, and so on. Hopefully a healthy, clean diet, getting back to the Greek, prescription for health. It's diet, clean diet, work, exercise, relationships, love, balance in your life. This could help you. And what we've talked about with, where is this acting? It's acting at our DNA level, among others. There are many targets in the body, but we're also affecting potentially longevity and decreasing the senescence effects. So I tell people we start with repair. We do a block of treatment, and then we look symptomatically on intermittent treatment on a longer term. So this could help you.
Yeah,
Yes.
Beautiful answer, and I appreciate that. And I do, it's interesting, about 5 years ago, I really changed some habits, and people ask, like, how do you train for the things that you do? I'm still running 100-milers and that kind of thing. I'm like, well, the top priority is sleep, far and away is sleep. My second priority is hydration. My third is, nutrition and diet. I don't like the word diet, and I'm so glad to hear you say
Yeah.
Yeah, I'm so glad to hear. Say like a Greek diet, or because I've never fasted other than, I try not to eat past 7 o'clock at night, and I wake up in the morning and I eat when I'm hungry, not on a schedule.
Yeah.
And I know there's always a new cool diet and things to do that. But I think that it's mostly just eating, as you said.
That's what I'm using the term diet as.
Yeah, no doubt.
Clean, healthy,
I understand.
balanced food intake.
Yeah.
Unadulterated, best you can.
I have one more question, and it's around, by the way, I did a few sessions here just this past week, because just yesterday, and this won't surprise you either, after about 160,000 miles of running in my life, I had PRP and hyaluronic acid injection a couple of weeks ago, and then another one yesterday. So I did a few sessions this past week before the knee injection yesterday. So we'll have to wait and see how it goes after a little bit. But I was very encouraged by the folks here, right here at this facility, that gave me what I think was some really good advice to get that done and kind of hypercharge things before I got that injection. The question is, starting, and you've mentioned scans, brain scans, this and that, like how important is it if you're going to enter a period of time where you're going to do 20 or 40 or 60 sessions or whatever that is, to get a before and after look? I understand that ideally you get before, during, and after, but like how important is it to get some sort of a look? To my knowledge, I've never had a brain scan unless somebody did it while I was sleeping or something.
It's only if you want proof.
It's only if you're curious, or if you need it for court.
If
I
you want
am
to know what your
curious.
brain looks like and see what state it's in.
I like data,
Okay,
so
get a
I
functional
would
brain
love.
scan. But I'm using it to initiate the dosing and looking at the response to multiple doses. I don't do it in the middle of it unless, it didn't give me a good indication, the patients aren't really improving, or they are, and now it's, well, do we want to take a look at some others or finish? But it's not, spec brain imaging, for instance, I only do it in legal cases now, where I have to be documenting, because if we show improvement, it's potential that it's going to have to be in a life care plan. So it's a matter of proving it on that patient with as much documentation as we can get. But the average person who comes to see me, I don't spec brain them. I do strongly encourage them to do, let me QEEG dose them at the beginning. But it's only if you want to. If you want to demonstrate for yourself, you're the engineer, you want some hard proof, before and after, then okay, go ahead and do that documentary spec scan to begin with, and then at some point after. But they're tricky.
But he's already had a few treatments, so your brain is forever changed.
Yeah,
So
but
you don't know what your baseline is. 'Cause
Tell
you
my
already
wife
did.
that.
true, but I mean, you're still, if you're embarking on, let's say, a prolonged course and all, you can start and document it that way if you want,
Yeah. Thank
It's
you
not
so much.
necessary.
Yeah, really amazing. Thanks so much.
You're welcome. Pleasure.
So we have some more questions. I think we're good. We can wrap it up, and I just have to say, I hope you come back. And
Well, if you invite me, I'll come back.
and
Sure, I'd love to.
It's really been quite an education.
It's a great forum.
Yeah, I appreciate that, and I hope that anybody watching this recognizes the value of your experience, and comes back to follow the conversation that we've had for the last 2 days. I think we'll have 6 or even 8 segments on the conversation that we had, uncovering many of these topics that are in your book, and that they reach out and get the book. And
Well, and I would say one other thing. I mean, the whole point of this is exactly what we had talked about earlier, and what the original goal was back there in 1989, 1990, in these early cases, was to try to get the word out. And that's what this is attempting to do. But what I'd also plug is for people to go online and search Harch Systematic Review or Harch Frontiers in Neurology to get the systematic review on hyperbaric oxygen in mild traumatic brain injury, persistent post-concussion syndrome. And look at that, because it discusses many of these topics in the discussion section, yeah, there's all sorts of data and all sorts of other things, but it also, for the first time, looked at studies and the dose of pressure and the dose of oxygen, and what it showed was the pressure was the more important one. That there was a broad range of oxygen dose that seemed to work, but the pressure was probably the most important or dominant effect. But in there is discussed these controversies and how this all fits, and finally leads to the conclusion that this meets the highest level of evidence. It can be used now for patients to try to get reimbursement for this therapy from their insurance company, because that diagnosis isn't on the routine list. So on first application and submitting the bill, they'll probably get it rejected. But on appeal, it goes to an appeal committee where you can present the evidence for the therapy that you had. And what they want to see is randomized trials. Here are 6 randomized trials now, and a systematic review, and no dissenting opinion yet on that.
Well, I know in one of our conversations, we got pretty deep into the insurance piece.
Yes.
And strategies on getting reimbursed, for
Right.
treatment. And so I think that's a value, and we have some projects, I think, that we talked about to make it easier and to take this a little further faster. And there is a sense of urgency, clearly, with this project, and as...
There was a sense of urgency in 1990,
Well, yeah, it hasn't changed, and I think it's
Yeah.
accelerating, especially with, you're looking at long-haul COVID, and we talked about
Yes.
that. We talked about the vaccine injuries and some of those that are coming out and showing up at the clinics, and so covered so many topics, and I think it's important for people to start to pay attention. And the studies you just talked about, those links will be provided with this, because of course this has been recorded and it's going to be posted, so someone couldn't attend, they'll have that opportunity.
We're now to the point of understanding this therapy for the first time in 360 years.
Yeah.
That's what it boils down to. And the results and the information is just undeniable. And the potential to change the quality of life, healthcare, even worldwide, is immeasurable.
Well, one of the things that you brought up earlier in your discussion with Dr. Stevens was the injuries that have occurred, people putting chambers in their homes, and I think it's important to see the medical professionals involved in the dosing and the actual therapy itself. One of the things that I like to point out is there's probably more people died of a drug overdose since we started this program that have died in the history of hyperbarics in the United States.
Oh, sure.
Of course, yeah.
Oh, yes.
And so it is a drug, and the pressure and the oxygen are components, and the time, as you brought up earlier, and maybe the levels and the cycling of that and the number of treatments, all important, and that's why it's important to seek out some medical advice with the expertise like yourself and Dr. Stevens that have experience in this area. So I hope people understand that, and that they don't see any concern or fear in that, just going to the right place. I think it's important to seek out that professional. Just because you read this book doesn't make you an expert.
No.
But I think you'll get the point that there is hope, and if anything that this program, I think, should give people is that there's hope and there's a spirit of humanity behind this project. And I use that term not lightly. Mal Hooper from Australia always says the spirit of humanity. That's what brings the hyperbaric oxygen industry together. So thank you again, and thank you for coming, and I hope everyone has enjoyed this segment presentation.